High-yield neurology and neurosurgery clinical vignettes. Let's get right to the cases.
Questions 38 to 40.
Okay, let's dive into this. Which of the following signs in a patient with a head injury alerts a neurosurgeon? The correct option is A, bradycardia. Now, you might be wondering why. Well, bradycardia is an absolutely crucial component of Cushing's triad. It's literally a blaring alarm for severe, decompensated intracranial hypertension. Basically, it's an immediate warning sign of impending brainstem herniation, and that requires urgent surgical decompression. The full triad? It consists of bradycardia, hypertension, specifically with a widening pulse pressure, and irregular or bradypneic respirations. Let's think about the physiology here for a second. When high intracranial pressure starts choking off cerebral perfusion, the body panics, right? It triggers this massive systemic sympathetic surge just to force the blood pressure up, and that surge is then followed by a baroreceptor-mediated vagal bradycardia. So, seeing this in a head trauma patient, it means you've got advanced transtentorial or tonsillar herniation happening, and you need immediate hypertonic or surgical intervention.
Next up, which of the following is the most common benign brain tumor? The correct option is A, meningioma. Meningiomas are actually the most common benign primary intracranial tumors overall. They originate from the arachnoid cap cells of the meninges and make up about 20% of all primary brain neoplasms. These guys are typically slow-growing, extraaxial, benign WHO grade 1 tumors. They do show a marked female predominance, with peak incidence hitting right around 45 years of age. And for exam pearls, histological evaluation characteristically reveals these sheets of meningeal cells arranged in whorls, and they contain these little nested calcifications we call Samoma bodies. For treatment, complete surgical excision is absolutely the definitive choice here.
Now, in contrast, which of the following is the most common brain tumor overall? The correct option is B, glioblastoma. You'll also hear it called glioblastoma multiforme or a WHO grade 4 astrocytoma. This is the most common and unfortunately the most malignant primary intraaxial brain tumor we encounter in adults. To put that into perspective, widespread gliomas make up about 60% of all primary brain tumors. Glioblastoma is notorious for its aggressive microinfiltration, a super fast doubling time, and a classic radiographic look. A large necrotic mass with irregular ring enhancement. It's a tough diagnosis. Despite aggressive multimodal therapy, the long-term prognosis remains quite poor, with a median survival of roughly just 12 to 15 months.
Moving on to questions 41 to 43.
Now, what's really interesting about this slide is the statistical reality. A 60-year-old otherwise healthy woman presents with a 3-week history of severe headaches. A contrast CT scan reveals a small, circular, hypodense lesion with ring-like contrast enhancement. So what's the diagnosis? The correct answer is option D, a metastatic lesion. You see, in an immunocompetent adult, secondary metastatic disease is statistically the most common cause of a newly identified ring-enhancing intracranial mass. Fact is, intracranial metastases outnumber primary brain tumors by an incredibly wide margin. They show up in up to 15 to 30% of all systemic cancer patients. The primary tumors that most frequently metastasize to the brain are lung at 40%, followed by breast at 15%, melanoma at 10%, and renal cell carcinoma also at 10%. And structurally, they tend to accumulate preferentially right at the gray-white matter junction, basically where the tapering vascular calibers trap the traveling hematogenous tumor emboli.
Let's look at a forensic scenario. A 60-year-old lady is found dead in her bathtub. On detailed autopsy, bilateral subfrontal contusions are noted, along with subarachnoid and intracerebral hemorrhage. The likely cause of death? That would be option B, a mechanical fall. Identifying bilateral subfrontal contusions at autopsy is a classic telltale indicator of a blunt deceleration impact. It happens because the mobile brain literally sloshes forward and smacks against the rough, bony floor of the anterior cranial fossa during a fall. Traumatic contusions preferentially develop right along the orbital surfaces of the frontal lobes and the anterior poles of the temporal lobes, all thanks to those projecting internal skull ridges. Just remember your dynamics. Contusions directly beneath the site of external impact are called Q injuries, while those occurring in the neural tissue directly opposite the impact, due to inertial shifts, are contra-Q injuries. This pattern is exactly how forensic pathologists differentiate a primary fall from a spontaneous subarachnoid hemorrhage.
All right, next case. A middle-aged patient presents with seizures and projectile vomiting. The CT scan of the brain shows a supratentorial, homogeneous, densely enhancing space-occupying lesion with a broad base of attachment along the dural convexity. The diagnosis? Option B, meningioma. Tying this right back to what we discussed earlier, a contrast-enhanced head CT showing a well-circumscribed, extra-axial, homogeneously and densely enhancing mass with a broad-based dural attachment is the absolute classic radiographic presentation. You really want to look for that pathognomonic dural tail sign highlighted here, as well as the occasional central calcification. Because these grow extra-axially, they physically push and displace the adjacent brain parenchyma rather than infiltrating it. And remember, getting a complete surgical clearance, a Simpson grade wire resection that includes the dural attachment, is what gives the patient the lowest long-term recurrence rate.
All right, questions 44 to 46. A 45-year-old right-handed lady is being operated on for a meningioma that's compressing her left parietal lobe. Which of the following is consistent with dominant parietal lobe dysfunction? It's option D, Gerstmann syndrome. So, the crucial point is that in a right-handed individual, the left cerebral hemisphere is dominant. If you have structural damage or compression in the dominant parietal lobe, specifically the angular gyrus, it knocks out some very specific cognitive networks. Clinically, this presents as Gerstmann syndrome, which is defined by a distinct clinical tetrad. We're talking agraphia, which is the inability to write, acalculia, the inability to do mental math, finger agnosia, meaning they can't identify individual fingers, and right-to-left disorientation. Just as a quick comparison, if the lesion was in the non-dominant or right parietal lobe, you'd see hemispatial neglect instead. Here's a true emergency scenario. A patient presents with sudden onset of severe headache, describing it as the absolute worst headache of their life. You're suspecting a spontaneous subarachnoid hemorrhage. So what's your first-line investigation? It's option B, a CT scan without contrast. Whenever you hear thunderclap headache, a non-contrast head CT is your go-to. It provides a rapid, highly sensitive check for acute subarachnoid blood pools sitting in the basal cisterns. In fact, it has a diagnostic sensitivity of over 98% if you do it within the first 12 hours. Radiographically, acute subarachnoid blood creates this classic, very bright, 5-pointed star appearance right in the center of the cisterns. Now, keep in mind, if that CT comes back normal, but your clinical suspicion is still high, you absolutely have to follow up with a diagnostic lumbar puncture to check for xanthochromia.
Let's look at visual defects. A patient with left homonymous hemianopia or quadrantaniopia, along with aphasia, will have a mass lesion located where? The correct answer is option C, the right cerebrum, and this brilliantly illustrates how the visual pathways are mapped out. A lesion involving the temporal lobe compresses the lower fibers of the optic radiations, known as Meyer's loop. This gives you a pathognomonic contralateral homonymous superior quadrantaniopia. Clinically, we often call this a pie-in-the-sky visual defect. On the flip side, parietal lobe lesions compress the upper fibers of the optic radiations in Baum's loop. That presents as an inferior quadrantaniopia, which we playfully call pie on the floor.
Let's finish up with questions 47 to 50. Which of the following mechanisms is directly involved in vasospasm following a subarachnoid hemorrhage? The answer is option D, blood. Here's what happens. Cerebral vasospasm is this delayed reactive narrowing of the large intracranial arteries. It's driven directly by the physical presence of blood breakdown products, specifically oxyhemoglobin sitting right there in the subarachnoid space. These breakdown products irritate the vessels, inducing smooth muscle dysfunction, endothelial damage, and localized vasoconstriction. Clinically, this characteristically shows up between 3 and 14 days post-bleed, but it hits its absolute peak at day 7. It's actually a leading cause of delayed cerebral ischemia in these patients. That's exactly why oral nimodipine, which is a specific calcium channel blocker, is started immediately as prophylaxis to improve outcomes and reduce those ischemic deficits. A 50-year-old male is brought in post-motor vehicle collision. On exam, he has motor weakness, but it's significantly worse in his upper limbs than his lower limbs. What's the diagnosis? It's option E, central cord syndrome. This is an incomplete spinal cord injury that is absolutely classic for hyperextension trauma, especially if the patient has pre-existing cervical spondylosis. What happens is the edema maps predominantly to the centrally running corticospinal tract fibers, and those are the ones supplying the upper extremities. The more peripherally arranged fibers for the lower extremities are largely spared. It's actually the most common incomplete spinal cord injury syndrome we see. In the ICU, management is all about hemodynamics. You need to strictly maintain a mean arterial pressure of 85 to 90 millimeters of mercury just to keep that damaged spinal cord optimally perfused. Next up, a patient hit by a car, complains of severe back pain, is hypotensive at 80 systolic, has absolutely no sensory motor response below the level of the lesion, loss of anal tone, and an absent bulbocavernosus reflex. The diagnosis here is option E, spinal shock. Spinal shock is this immediate yet transient loss of all neurological, motor, sensory, and autonomic reflex functions below the level of an acute cord injury. It is absolutely critical to distinguish this from neurogenic shock. Neurogenic shock is a hemodynamic problem, hypotension, and bradycardia from a loss of sympathetic tone. Spinal shock, on the other hand, is a neurological state of transient reflex loss and flaccid paralysis. You know it's clinically coming to an end when you see the structural return of that bulbocavernosus reflex.
For our final vignette, we have a 33-year-old quadriplegic with a historical C6 fracture. He presents with a severe throbbing headache, profuse sweating, a skyrocketing blood pressure of 210/100, and a heart rate dropping to 45. What is your priority administration? It's option B, sublingual nifedine. We are looking at autonomic dysreflexia. This is a massive, life-threatening emergency that happens in patients with historical spinal lesions at or above the T6 level. It's usually triggered by a totally uninhibited sympathetic discharge responding to a noxious stimulus below the injury, like a distended bladder or fecal impaction. This reflex causes intense runaway vasoconstriction and severe hypertension below the lesion. Meanwhile, the brain detects the high pressure and tries to compensate with a vagal response, which causes the severe bradycardia and flushing you see above the level of the injury. You have to immediately elevate the head, clear the stimulus, and give rapid-acting antihypertensives like sublingual nifedine. It truly leaves you marveling at the delicate, tightly regulated balance of the human nervous system and just how violently it can swing when that central control pathway is suddenly severed.